For our training, I want to make sure that you are at the correct training, which is unlocking and treating depression in adults with IDD. Okay, I don't want anybody, what? You're not doing end of life? No, it's about unlocking and treating depression in adults with IDD. Okay, get that coffee now. So here's the criteria for successful completion. You must check in, you must have registered, check in, and attend the entire conference and complete the evaluation form to receive a certificate. We have both CE certificates for nurses, social workers, and counselors. And we also have a certificate of completion for those other professions, okay? And I think I used the word other profession. I didn't want to use the word other professional, because sometimes that gets misconstrued. So there you have that. This is the learning outcome. Participants will agree that they are now able to recognize symptoms of depression, can access screening tools to assess for depression, and can help the individual with IDD to receive treatment for successfully managing their depression, which may include the use of psychiatric medications. Please make sure that your email and name is spelled correctly, as this enables us to contact you regarding upcoming trainings and to do surveys, as well as send you back your certificate. There are no conflicts of interest for the planners of this activity. There was no commercial support for this C&E activity or for the social workers. Please make sure you understand that, because if you do check that there were commercial supports, I don't know where the money went. I mean, somebody needs to send me the money, because there was definitely no commercial support with this. To be respectful to the presenters and others seated around you, everyone will be on mute, but you must keep the video on, okay? Everyone has to put the video on. And I know I'm going to be chastising a couple of people, but for us to be able to confirm to the entities that give us the right to provide CEs, we have to see you. I don't care if this is a bad hair day, okay? I really don't. I don't care if your cat crosses past. It's all right, okay? And for some of you, if you'll learn about Zoom, you can change the background. So if you didn't clean that room, change the background. We have one of the San Francisco Bridge, and all kinds of good stuff. Or load up a good, appropriate picture as a background, then we're good to go, okay? So don't worry about that. And we're just so glad you're here. We don't care how you look. I'm not going to call you back up, believe me. Okay? So those are the things. You each received an evaluation. Please make sure you indicate what your credentials are. And this is very sensitive, so if you accidentally checked a box, click back out of it, and then go to the correct box. Now, some of you are both, social worker and nurse. That's fine, but make sure, okay? And once you complete this, then send it to me. Send it back to me, because I sent you the link. Send that back to me, and then I will send you the appropriate certificate, okay? And I usually do that within about a week or so of you sending me the email with your evaluation. Please send it in either PDF or Word. Please don't send it macro, micro, grandma, whatever you have. It's got to be PDF or Word, and then I'll be able to send you the certificate. Okay. So I think that is it of the announcements. So it's been 4 years since the presenter, Molly, has been with us. Matter of fact, we were still downstairs. So it's been something else to tell us, no, we're up here, which is really a wonderful thing. Molly, in addition to being a mother and a wife, she is an associate professor. She has her PhD. She is a nurse. She has been a psych nurse for a long time. And she is a licensed social worker. We're talking about a magnitude of great things in this wonderful woman. So I am so proud and so glad to present, if they are ready,
Not quite.
in 30 seconds, I will be so proud to introduce our wonderful presenter who we've known for a long time. And for those who may remember, she used to be the DDMI clinic coordinator, the Developmental Disability Mental Illness Clinic. She used to be our coordinator. So now I can introduce my beautiful friend, the marvelous Molly Faulkner.
Thank you, Ingrid. Appreciate it. Hi. It's really such a privilege to be here for a number of reasons. Number one, I haven't left the house in ages to present. I do a number of lectures online for a bunch of different things, but I'm so delighted to be here again with Continuum of Care, and just to be able to be in a room with other human beings and not wear a mask, although people are way away from me. And I won't be doing any sneezing or singing today, I promise. Yeah, I am Molly Faulkner. I've worked with many of you that are probably online today, and I usually, when I do these presentations, I can see people. I can even see when I'm working online, I can see everybody that's attending. And so I appreciate you being here today, and also, you know, talking about this really difficult topic in general. I'm going to talk a little bit about not only how depression affects individuals with intellectual disabilities, but I'm also going to talk a little bit about how it affects all of us, because I think that we are all have been impacted by COVID in the last 6 months, and I think just in general we're impacted at some point in our life by depression. I need to ask my audiovisual individuals if you can see me, if it's okay if I move around. Okay, thank you so much. I do better when I'm moving. And I'll try my best. If I get too close, just put your hand up and I'll go, oh, that's right, I'm not supposed to be there. So I'm currently, I am an associate professor at the Department of Psychiatry here at the University of New Mexico. I work in the Division of Community Behavioral Health, and we do a great deal of outreach to the whole state, and sometimes even nationally, and some of the work we do with grant writing as well as program development. I do a clinical supervision program for social workers wanting to obtain their independent clinical license, a free program actually for the state. So there's just a number of things I do in my job. I also have had, I'm just trying to think how long. I've been a nurse for 38 years, and I've also been a social worker for 28 years, and then I became a nurse practitioner 18 years ago. So I've been working with children and families for a long time. And primarily I do child and adolescent psychiatry currently. I do a telepsychiatry clinic in Pine Ridge, South Dakota that I've been doing the last 4 to 5 years. And I also, as Ingrid introduced me earlier, I was the consultation clinic coordinator, where we would go around the state and do consultation clinics for individuals with developmental disabilities and intellectual disabilities and mental illness. And so I have, and I really enjoy the opportunity to talk to people about different topics, and I learn as much from you, believe it or not. I learn lots from y'all, as much as you might hope. Well, I hope you're going to learn from me today. So the background of individuals today, as my assumption is, and I know somebody is looking at all the people online, but my assumption is we've got social workers on the line. Is that right? Yes, okay. We've got counselors possibly. We've got direct caregivers, maybe family members, okay? So there's a whole variety of people, and if you were sitting in here with me today, I'd ask you to shout that out. So what are you not a nurse? I'm sorry. Tell me your role. You are a social worker.
Yeah, we also have care coordinators with the MCOs online.
Excellent.
Consultants and case managers potentially too.
That's great. That's great. I love care coordinators. And yourself?
I'm a registered nurse.
Awesome. Awesome. So it's great to have everybody, and I always say that I appreciate an interdisciplinary team. I always have, and I always will, and it looks like that's what we have online with everybody. So this is a picture that somebody who was depressed actually drew, and I think it's a very interesting picture because it just demonstrates how you can see a lot of the tension and darkness in this particular picture. This looks like a dragon or some type of a chicken, or it's hard to tell what this is here, and you really don't interpret it ourselves. You let the individual kind of interpret it and tell you what it means to them. But art is one of the most beautiful interventions to utilize with people who are suffering from any kind of mental health issue, Art's great for any of us to practice at any time, but I wanted to start with this picture today. So the overarching goal today is to discuss depression, assessment, interventions and use of psychiatric medications in both general populations. Like I said, I'm going to talk about just the typical population and the developmentally delayed mentally ill population. So our objectives today, we've got a lot of them, are to list the prevalence of depression in general and intellectually developmentally delayed populations. Because we're going to talk about how common is this, right? And then we're going to talk about, I'm going to identify the range of depressive symptoms in the general and intellectually delayed, developmentally delayed populations. We're going to describe the impact of COVID-19 and the pandemic upon general and IDD populations, outline a basic assessment for depression in this population, recognize evidence-based psychotherapeutic treatments, because there are evidence-based psychotherapeutic treatments for depression and IDD population, and I'm going to state evidence-based psychiatric medications for depression in general and for intellectually developmentally delayed populations. So I just wanted to tell you, I'm going to talk about facts, depressive illness on a spectrum, because if somebody's depressed, they're not just one, not everybody's depression looks the same, and not everybody's depression is as intense or severe, right? Because we're going to talk about it on a spectrum today. And also discuss risk factors as well as diagnosis. And then we're going to talk about the extent of the problem in adults, adolescents, and children. This is a definition of depression, and I hope you can see it on your screen. It occurs to me that this may be a little washed out here. Major depression is really different than just simple depression. Major depression is a serious emotional and biological disease, and it really affects our thoughts and our feelings and our behaviors, and our mood and our physical health, and we're going to talk about that too today. Sometimes it can be a lifelong condition in which periods of wellness alternate with recurrences of illness. If you have a major depressive episode, and we'll talk about the specific criteria of that later, but if you have a major depressive episode in your life and you recover from that episode, you are more likely to have another episode. If, in particular, you do not follow, a good treatment plan regarding taking medications, maybe doing therapy and trying to change your thinking around your thoughts and your behaviors, and exercise and eating right. So, but just to let you know, once a major depressive episode has occurred, people are far more likely to have another one. That doesn't mean they will, but it just gives them that predisposition. And the definition of depression is a normal human emotion that we sometimes call depression is a common response to our sense of loss or failure or some kind of disappointment. And that loss or failure can be related to something that we feel about ourselves, or it could also be related to how we perceive others feel about us, right? So it could be either that. And it might require long-term treatment to keep symptoms from returning, just like any other chronic medical illness. And it often has a developmental trajectory, meaning that there are certain periods in a woman's life that they have more susceptibility to depression. One is when they start their menstrual cycles in their teen years. Another is when they are in their reproductive years and when they're after having a baby. And then another one for women is certainly around the time of menopause. Men have another developmental trajectory that's a little different. Often their first episode of depression isn't until way after their teen years. But you can see some children and adolescents that are depressed and have a major depression. Men also will have more depression if they see a change in their job status, in their financial status, in their marriage status or relationship status. And often, as we speak here in a little bit, I'll tell you, as elders, men, especially white men, as elders, are highly, highly susceptible to depression. And it's important that we know that so that we can think about it ahead of time and kind of head it off. In the general population, we know that the prevalence of major depression ages 12 and over in any 2-week period is 7.6% of all of us, right? Our lifetime prevalence is quite broad. It's like 4.9 to 17.1%. And one reason why we have such a large gap or large spectrum here of a percentage is because it's not always an easy thing to diagnose. It's also not always reported the same in all the literature. We know that people living below, this is regarding health disparity and why it's so important, but people living below the poverty level were nearly 2.5 times more likely to have depression than those that or above the poverty level. That's important for the people that we work with. And again, we were talking earlier about the women's prevalence as more susceptible at certain periods of their life. Well, we know that women are 70% more likely than men to experience depression in their lifetime. And they feel like some of this is related to our hormonal influences, also of all the multitasking we do and all the different challenges we have in, and also the access that we have to our emotions. 15 to 20% of adults older than 65 will experience depression. We estimate that 25 million Americans affected by major depression in a given year. Depression is the leading cause of disability and the second leading contributor to global disease. Now, this is interesting to me because when I first gave this presentation about 4 years ago, depression was going to be the leading cause of disability and the second leading contributor to global disease in 2020. Well, we are here in 2020. So we know that depression is that major leading cause of disability now. 10 to 20% of mothers after childbirth have depression. This is that postpartum depression that many people hear about and talk about. We know that a patient's culture, gender, and or predominance of somatic symptoms can really impede that detection of depression. In other words, people coming in to see their primary care provider may not present as somebody saying, I'm feeling depressed or I'm feeling sad. That may not be accessible to them in how they express what's happening in their body. They may come in with a headache, a stomach ache, or some other kind of physical problem. You may have somebody come talk to you about how angry they've been and how irritable. They can tell they're irritable, but they do not categorize that for themselves as a depression. That often is picked up hopefully in the assessment. But again, we know that culturally, people don't necessarily present similarly with these symptoms of depression, and also we as clinicians don't always pick it up, right? We don't pick it up in others. Up to 70%, this is a very important point, up to 70% of individuals with depression are seen by their primary care provider, their nurse practitioner, the PA, or their physician, and up to 50% are misdiagnosed. So the first time they go in to talk to their primary care provider about their depression, most of us enter that system, if we have depression, through our primary care providers. And we know that about 50% of those individuals are misdiagnosed, that depression is actually missed. And so there's a missed opportunity to kind of help and treat that. One of the reasons I have found this to be true is that we often, number one, primary care providers are really trained to deal with physical health concerns. We get a very small, I'm a family nurse practitioner that's done child psychiatry my whole career, and my education as a family nurse practitioner had a very small amount in mental health and a very small amount in psychiatric illness. So they're not even trained in this, but also, even if they are, they may not have a good method of referring that client. I'm sure you care coordinators in the audience could attest to this, or anybody working in case management and trying to help people find care. We don't have enough providers in the community, and sometimes our primary care providers are reluctant to do a full assessment, mainly because it's tough to find a place for that individual to go see and get that treated. In the general population, we're going to talk about depression in adults. The average onset, and we're talking men and women, the average onset is age 32. I put a man in this picture because I feel like we need to really blow open the perspective that men don't get depressed. They absolutely do. And the issue is that they don't always go talk to people about it. That this young man is talking to someone about that. Again, 50% treated in primary care. Not uncommon to have both anxiety disorder and depression. I'm sure many of you know that, but I always bring it up because people often see these as discrete issues. I was talking to a young woman yesterday, 17 years old, who has post-traumatic stress disorder, and her primary issue is anxiety and panic. She has that as the primary issue. Does she have depression? Oh, yes, she does. but it is not something that makes her want, that she thinks has hard time concentrating or feels guilty. That's not the primary symptom. Her primary symptom is that anxiety. So if you have somebody come in with anxiety, you should actually look for depression, because quite often it's underlying and you're not hearing about it. And if you have somebody come in with depression, you should always assess for anxiety. This is what I was talking about earlier about a depressive illness on a spectrum. So on this end of the slide, of this spectrum, you have a psychotic depression. So this is a severe depression where people actually get psychotic, meaning that they have lost touch with reality or they've had a break with reality. This does not mean that they have schizophrenia. Okay, that's a completely different syndrome, and we can talk about that another time. But this, we're talking about depression. And then you can have people who are depressed. They might be dysthymic. This is stable right in the middle, okay? And then they might have that swing on the other end where they might have a mania or be hypomanic. They might get to mania, hypomania, and then manic, and then psychotic mania. So what's important for me, for you to understand, is that this can be, anybody can be seen on this spectrum. You can have a transient sadness. People can be grieving. I've been doing a series of lectures on grief lately, which has been quite educational. I think I know a lot about grief, but I never knew enough, as much as I'm learning now. Grief is with us a lot these days, and certainly is, we experience depression in grieving. Adjustment disorders, so people are having a difficulty adjusting to a new situation. In this population that individuals are working with for continuum of care, you might see an individual who is having to shift homes. They're transitioning from one home to another group home, or maybe from family home to a group home. And they might have an adjustment disorder around that period of time, and they might have some depressive symptoms. You might have dysthymia. Dysthymia is really a low-grade depression. It does not meet criteria for full major depression, okay? But it does, but this is somebody who just chronically feels a little off, okay? They don't ever get suicidal. They're able to function, they go to work, but they're just not really feeling up to their full potential for their life. And then we have major depression. And then bipolar illness is a part of the depressive illness spectrum. So it's always important to look at your client if you've not known them well. Okay? If you've not known them well, if you just meet somebody and they're in a depressive state, it's always important to ask if this person has ever had a manic state. Because often when people are depressed, they have no memory of ever feeling manic. So that's why I included on this slide. That somebody may come in with what appears to be a depression, but then you find out later that they actually have a bipolar illness, and that bipolar is that swing from that depression up to a kind of a severe depression, up to a mania. Not everybody with bipolar gets psychotic. Not everybody does. That's a type 1, can possibly be a type 1. Bipolar, where people get hospitalized and they have that wild mood swings. A type 2 bipolar is more depressed and irritable, and they rarely get manic. They're usually just come back to a kind of a normal. And I'll show you this kind of, a little bit of what I'm talking about here. Okie doke. So this is what I was talking about earlier, and just as another example of how to conceptualize mood issues. We have this upper limit. Oh, I'm going to start in the middle here. This line right here, I don't know how many times I've drawn this out for families that I've worked with, but this line right here is where hopefully all of us are at any given day. We're kind of in the middle. We feel pretty good, and we might be somebody that just always sees the optimistic side of things, you know, Pollyanna maybe a little bit, but you might be here, right? Or you might just feel like you're just a little bit below, but hopefully you're kind of going up and down and you're really here, right? That's the average typical individual with no depression or mania. But then you have people who go through really wild mood swings. And this is an example of somebody that might be in the middle. They're not quite manic, okay? Manic would be staying up for days on an end, or buying things, talking in a pressured manner, talking a lot. Pressured meaning I want you to hear what I'm saying, and I'm not giving you a break to even think about what I'm saying because I'm talking so fast that my ideas are flowing one into the other. So that's what I'm talking about, pressured speech. And I might sound a little bit like that today, but I'm trying to get through all this material. But I promise you I've not been diagnosed with bipolar or hypomanic. So, but anyway, so then you have good times and bad times, but usually people with more of a mania, bipolar, will have this huge kind of swing, right? Folks that might be down here a little bit will be more of a subsyndromal depression or dysthymia. I was talking about that word dysthymia. It's not on this slide, but that's what I'm seeing here. And then you have people that have the lower limit of normal mood where they are majorly depressed, okay, way down here. And the upper limit of normal mood where they have this happiness and joy. And these individuals also, if they're manic or hypomanic, they might be hypersexual. They might be, and when they get psychotic, they might think that they literally are some important person like the King of England. And seriously, I've met somebody like that one time when I was working at Las Vegas Medical Center. So you can really have a psychosis associated, like I said, with manic behavior and with severe major depression. So I'm just putting this up there for consideration. If I don't have a symptom that you have experienced or somebody you work with has experienced or know, it's not for lack of trying. So I'm trying to show you that we have a variety of symptoms of depression. We have cognitively, and I also wanted to kind of tell you that we express those symptoms differently. We think about things differently when we're depressed. We have a hard time concentrating, thinking. Our thinking gets slowed. We have a hard time kind of putting it all together or accessing different ideas. We might be obsessive or ruminative. It was really hard yesterday. I was talking with a young man who is, and I've known him for some time, thank goodness, because I think that if you know somebody over a period of time, you get a better sense around what bothers them or when you're going to see them kind of have lower moods. And this young man has obsessive and ruminative thinking. School started again, okay? And that's his thing. He's worried he's going to fail. Has he ever failed? No. But he's worried he's going to fail. And if he fails, he's going to disappoint his dad. And if he disappoints his dad, he's not going to go to college. And then he loops around again about what that means for him. So this young man that I was chatting with, he has a chronic issue with obsessive and ruminative thinking, okay? And also this can be a part of anxiety too. Obsessive and ruminative thinking also be a part of anxiety. People have a loss of confidence in their thinking. They have self-blame. They have difficulty making decisions when they're depressed. Behaviorally, in major depression, you're going to see people have a loss of functional self-care skills. If somebody walks in your office or if you go see them on the Zoom or however you're meeting with your clients and they look disheveled and they never did before, you need to wonder whether they just overslept that day or as there actually a change in their mood, because often people will not take good care of their personal hygiene when they are feeling bad about themselves. So you have that loss of functional or self-care skills. And in some of our clients, you might actually see their ability to they might regress in their abilities. They might actually, where they were able to take care of their own personal hygiene, now they want you to help them. Where they were able to wipe themselves in the toilet, now they want you to help them. And you're like, my gosh, you've never needed me to do that before. What's that about? Well, that's an indicator. Anytime somebody has a loss of a functional or self-care skills, you should think about depression and illness, because that's unusual. Sometimes people get aggressive when they're depressed. Males are far more likely to be aggressive and irritable. It's just the way it's expressed within them. I think it has something to do with testosterone, but I don't have the exact biochemical thing. But that's the only thing I can think is wildly different. And I also think that men are taught to deal with their depressive feelings differently than women are. You might have thoughts of death. People might start thinking about their own death or demise. They don't have to actually have a plan, although you need to assess for that, but you might see these thoughts in people who are depressed. And again, like I said, they might have suicidal thoughts, actions, or other self-harm. I had a young woman last month who had a desire, she kept trying to bump into things so she'd hurt herself. That was her kind of thing, and she really was slipping back into a depression. That young woman that I work with had a mild intellectual disability, but that's how she coped with things, is she'd think if she bumped into things that would hurt her badly enough that she might die. She didn't have an active thing, she didn't want to cut herself, kill herself, whatever, but that's what she wanted to do. Emotionally, we see people who are crying. That's a classic sign of depression, but that's not what you always see. You might even see just withdrawal. You might see somebody not being as social as they had been before, or just staying in their room more often, just not wanting to reach out. And that's a little tough to kind of ferret out in this COVID-19 era because we're all home. We're all isolated, right? But more isolated than usual. Again, anxiety, people feel guilty. They feel like they should feel better. Something's wrong with me. I feel guilty. Everybody's having to care for me and I don't want them to. I feel bad. People feel hopeless, worthless. They have low self-esteem, and sometimes they have depressive delusions. Like I had a young man, well, he's also psychotic, but I had a young man yesterday tell me that he has this person that follows him, and he finally looked at the person in his face and he said it was the dark side of me. And the dark side of him tells him that he's not wanted, that nobody wants him around. That's what he hears, this dark side telling him. So for him, it really becomes an active psychotic delusion because he has schizoaffective disorder, which is different. But people can have depressive delusions as well. Somatic, we talked about that. Somatic just means body. Soma means body, I think in Greek or Latin, I don't know which. But fatigue is a big one. People are sleeping more. They're hypersomnic, that's what we call it medically, but they're sleeping more. They get an 8-hour sleep and they want to take 2 or 3 naps in the day. I see that a great deal in my clients who are depressed. A headache or stomach ache is a big one. Aches or pains. They'll go in to see their primary care provider because they have an ache or pain, and they're not thinking I'm depressed. But then when the provider can't find a physical reason for the pain, then they start to explore, or should be exploring, underlying emotional contributors to that pain. People have heart palpitations, sweaty palms, sometimes in depression. You also have this quite a bit in anxiety. An increase or a decrease in appetite. Some people get so depressed they don't want to eat and they lose weight. Others, especially dysthymic individuals, often eat to comfort themselves. Oftentimes when people are depressed, you'll have early morning waking. These are folks that normally slept till 7 in the morning and all of a sudden they're waking up at 3 or 4, and it's persistent. It's not just a one-time thing, it's a persistent kind of change. And also an inability to get to sleep at night, waking during the night, that kind of thing. So again, I just talked about this. And just to let you know, a dysthymic or a subsyndromal disorder is at least 2 weeks of persistent change in mood, manifested by depression or irritable mood, loss of interest and pleasure, wishing to be dead, suicidal ideation or attempts, and decreased appetite and activity. And it's a change from previous functioning. That's another thing. When you meet somebody, you're trying to kind of get an assessment of how they are in general. But this is somebody, if you see a change, these are the behaviors that you're going to see. This is the diagnostic criteria for major depression. I'm really not so interested in that you know that. I just wanted to let you know there is a diagnostic criteria in the Diagnostic and Statistical Manual of Mental Health Issues, this DSM-5. And the reason why I'm not concerned about you knowing that exactly is if you are a clinician, a master's level, independent level clinician, or a doctoral level clinician like a psychologist or psychiatrist, you will know this. And if you can't remember the specifics, you will have a DSM-5 in front of you at all times. I do. I have a little book at my desk and I have a big book. So if I want to do a differential and I can't quite get what the differential is, I'll look at the bigger book. But I did want you to know that there really are specific symptoms. Okay, and I often look for children. It's much less time. In other words, that depressed mood is like, a week or 2. You know that's concerning because children don't usually have that. If you have adults, they often will have a longer period of time. This says 2 weeks or more defines a major depressive disorder. But usually people, by the time they come in to see you, they've been about 2 to 3, 4 months. Okay, at least. It's not a 2-week period. It's usually longer than that. So how do I know if I have depression? This is just for the typical person, right? How do I know? And again, I put a young man up here for a reason. Again, markedly diminished interest or pleasure in almost all activities nearly every day. And that's important. Is this happening every day? Or is it happening once a week? It's got to be an everyday thing. Now, I realize I'm repeating myself a lot, but that's what you do when you're trying to teach people. So I just want you to know I am aware that some of the items on these slides are similar to ones on the other slide, but I want you to definitely pick up these particular aspects of depression. Markedly diminished interest or pleasure in almost all activities nearly every day. Recurrent thoughts of death or suicide, not just fearing suicide. some of these folks are wanting to wake up, not wanting to wake up, excuse me. I almost said wake up dead. But some of these individuals want to be, die in their sleep, or if death found me, that'd be okay. Now, I've heard that a fair amount from people that are elderly and maybe have a chronic physical illness. They just feel tired, right? But that's an unusual thought for somebody at any age, and depression is not common in the elderly. I just want to be real clear about that, but I just brought that up as an example. A sense of restlessness, so kind of not being able to kind of get comfortable and feeling like you got to move a lot, you just can't, and you'll see this in an office. I've seen people have that restlessness. And I always, when I see the restlessness, I also look for anxiety. There's an old diagnosis that's not in the current DSM-5 called agitated depression. And that's when you have that anxiety and the depression kind of have an overlay on each other. And it's hard because they feel so bad about being depressed, and they feel that anxiety is permeating them. Or you might have somebody who's being slowed down. This is somebody who is talking slower than they usually might, or even kind of being like they look like they're kind of moving through wax or some thick solution, right? So their movements are slowed and their thoughts are slowed. Individuals can have significant weight loss or weight gain, and loss of interest in activities once enjoyed. So if you're thinking about yourself or somebody you love, or even some of your clients that might have developmental disability or not, these are, how do you know if they or if I have depression? You're going to have 5 symptoms simultaneously. That is actually from that criteria of the DSM-5, daily or nearly every day for 2 weeks or more. And you can have different severity, frequency, or duration of these symptoms. And these are the 5. A depressed mood during most of the day, particularly in the morning. So you wake up going, oh crap, another day, right? You wake up in the morning feeling really sad. Fatigue or loss of energy almost every day. Feelings of worthlessness or guilt almost every day. Like I am not able to, even though people tell me I'm doing fine at work, I feel like I'm just not up to my old standards, or I'm not good enough, right? I'm not doing what I need to do. Impaired concentration, just can't put it all together. Feeling like you're really indecisive, can't make decisions very well. Insomnia, an inability to sleep, can't fall asleep because you're worrying, or just can't fall asleep. Maybe people don't tell me they're worrying, but they just can't fall asleep. Anything longer than half an hour is really considered an insomnia of some degree, okay? Or hypersomnia, excessive sleeping almost every day. So you have to have 5 of these 6 simultaneously. Risk factors, I told you about this earlier. Prior episodes or episodes of depression. That is a risk factor, okay? Prior suicide attempts. If somebody was impulsively tried to kill themselves because something tragic to them, it was tragic and they thought their life was over, that would be a risk factor for additional episodes of depression. Being in the postpartum period, like I was saying earlier, a medical comorbidity. Say you've been diagnosed with Parkinson's, okay? That individual is at a much higher risk of trying to kill themselves. People with chronic pain, rheumatoid arthritis often comes with chronic pain. Any kind of medical comorbidity that limits your life or your feelings about yourself. Lack of social support. These are individuals that are isolated. That's why we're going to talk here in a minute about COVID's impact on all this, but that's why we want to be sure to reach out to people, because lack of social support is a risk factor for depression. Stressful life events. Haven't we all been having those the last 6 months, huh? It's been stress like I've never seen in my patients. And it's stress, and we'll talk a little bit about why I think it's just stress for everybody. We have global reasons that we're all feeling stressed, and we'll talk about that. History of sexual abuse. This is huge. I would say 50% of the young women, at least, that I work with have had sexual abuse of some sort. And they present with depression for sure, anxiety, and sometimes psychotic depression because they feel so bad about themselves. Current substance abuse. This current substance abuse is really one of those highlights that tells you, what are they trying to mask? What are they masking with that substance use? People don't just use substances and have problems with substances because they're having a good time. That doesn't usually how it starts. It might start like you're drinking to be like with your peers, or you're smoking pot or taking other drugs. But what usually happens is that continued use and the abuse potential comes from really trying to self-medicate, okay? So if you have somebody with current substance abuse, you need to look for depression. And again, here we go again. Women twice as likely to be depressed as men. Just know that women are always more depressed than men. It's just the way it is. And it starts with our onset of menses. Mm-hmm. If you look at your own life, or you have children, young girls, or anybody you know, and they've had issues with depression, you can almost always, if you help them kind of look back in their life, something started around that time. Just briefly, I want to talk about depression in children. The prevalence is 0.3% of preschoolers. Can you imagine? Get depressed? 2% of elementary school age children. I would dare bet this is higher now. I don't have the COVID numbers right now. I deal with children as young as 3 and as old as 23. I deal with older children, especially if they're developmentally delayed, or if they've had a serious mental illness and they move into their 20s. I'll keep them as a patient. But I have seen children as young as 3 depressed from abuse, okay? Ethnic prevalence, which I think is so critical. In one study of almost 10,000 students ages 10 to 16, found that almost 30% of American Indian youth exhibited symptoms of depression. A third, right, of American. 22% of Hispanic children, 18% of Caucasian, 17% of Asian American, and 15% of African American youth. So this is just one study, but this is a large, having almost 10,000 is a large number of sample. And this just tells you how it's distributed across cultures and ethnicity. In adolescence, we know that the prevalence is higher for major depressive disorder, 4 to 8%. Again, 1-to-1 males to females ratio before puberty, and 1-to-2 male to female ratio after puberty. For every 1 male that has depression, you'll find 2 females. By age 18, the incidence is 20%. 1 in 5 has depression. And a dysthymic disorder, which I told you was not major depression, but is that kind of sense of, life is just blah, has a prevalence of 1.6 to 8% in adolescents. There's a lot more going on in adolescence with hormonal changes and with identity. Kids are trying to figure out who they are and belonging, right? It's that age in the adolescence is when children's friends are far more important than their family, their opinion of their friends. And so they're trying to fit in, and they're trying to know where they belong in the world. And what I thought was sad but true, but they say since 1940, each successive generation is at a greater risk of developing depressive disorders, and depressive disorders have their onset at a younger age. So I'm not sure why that is. I can certainly have hypotheses, right? But I'm not sure exactly why that is. But just to know that we've had more problems with depression and suicide, actually, even in the last 10 years than ever before, and certainly in the last 6 months. Treatment of depression in childhood can help. It really does help, which is why I went into working with children and adolescents. I thought, wow, if I can catch people at a younger age to feel, and help them feel better and kind of process and learn about their feelings and emotions, then I can help them for life. So help prevent mental health problems or drug and alcohol misuse later in life. If we can treat depression in childhood, we can help prevent those problems or drug and alcohol misuse later in life. Adults seen for depression will be able to trace the origins to childhood or adolescence. It wasn't until the 70s, right? Though for me, the 70s, I was 20 in the 70s, but I think late 70s. But the point is that people didn't feel like children or adolescents had enough ego strength. This is what they talked about, ego strength, whatever that is. They felt like they just didn't have the developmental structures internally to be able to have a depression. So they didn't really start recognizing this until about the 70s. And that's good because they can treat it earlier. So now we're going to shift briefly and talk about depression in the general population. Pre and during COVID-19 pandemic. It's a great article by Ettman. And by the way, there's all these references are at the end of the lecture today. So you can look this up. We know that some of this must sound like, duh, Molly, we know this, but I'm going to tell you again. Mental health is sensitive to traumatic events. Mental health is sensitive to traumatic events. And what we're talking here is about disasters, like what's happening in California with the fires, epidemics, what's happening in the world right now, or civil unrest, which is what's happening with the racial inequities that are going along around the country. And here, his examples were 9/11, the Ebola virus. I think this was published in early 2020, right? I think that's why he didn't include, he did include COVID. But he also talked about the unrest in Hong Kong, civil protests that's been happening. But I can look right here in our country and look at Kenosha, Wisconsin, right? And all these, and Portland, and Washington, and everywhere, and golly Moses. So we know that our mental health is sensitive to these events. And in a nationally representative sample of U.S. adults 18 years or older, in the U.S. was more than threefold higher during COVID-19 compared with before the pandemic. So since the pandemic has occurred, our incidence of depression for adults has been threefold higher. Okay? That's enormous. They're talking a lot, at least even in recent lectures I'm attending or things I'm reading or educational presentations, they're talking about, or even the state, I was at the State Behavioral Health Provider Association the other day, and they were talking about the surge in mental health problems that are coming up, this pandemic of mental health issues, right? So we know this is an issue. So, and just the number is, the depression pre-COVID was 8.5, and now post-COVID it's 27.8%, and that is 3 times higher. 8.5 times 3 is about that. I don't do math great, but I know that. Individuals with lower social resources, lower economic resources, and greater exposure to stressors, these folks that have lost their jobs, people that can't, their finances are less than they were before COVID, they reported a greater burden of depressive symptoms. We know this, but I'm just telling you so that when you meet your clients and they may have had a job loss, or they may be lower socioeconomic status, you know that they're going to be at higher risk, and they really need to be given resources. COVID-19 and depression. Well, the reason why we're having that is because it's, is because it's a distressing, we're all experiencing this. It's distressing at an uncertain time. We don't know what's going to happen. We don't know the end to this. I was thinking this morning about the depression. My mother grew up in the Depression, as did my father, and as did many other people. And I thought to myself, here we are going into the 7th month of this in this country, of our shutdown, and these individuals lived 10 years with a depression, right? Well, understanding how this has impacted my clients and myself and my family and friends in 7 months, it's going to be really interesting. Thank goodness I don't think we're going to be dealing with this for 10 years, but it's just profound, and it gives me an even deeper understanding of what people have lived through in my family and in my parents' generation. The end may still seem like a long way off. I knew when we were told to go home on March 13th. That's when it happened for us, our office, on the 13th, Friday the 13th. I knew it would be at least a year before we came home. People kept saying, oh no, we'll be back in the office in 2 weeks. I said, I'm a nurse. I kind of know how these things go. We are not going to be back in the office in 2 weeks. We're not going to be back in 6 months. I knew this. So, and I'm grateful I had a sense of that, because it is still a long way off. But I've always had that sense in my mind that, it's going to be a while, but it's hard. It makes people feel sad and uncertain. Job loss. We've not yet seen, we know, what is it like? I know just this last month we had 800,000 job loss, and they said that was down, but that doesn't mean it's cumulative. I apologize. My husband could tell you to the nth degree how many millions of people are unemployed. I don't hold on to that kind of a number. And if somebody knows it, you're welcome to shout it out so we can all know it. But it's a fair amount of folks. Financial loss, right? The airlines are going under, right? These kinds of things. I'm not trying to make you guys more bummed out. I'm just trying to share with you what we know and why we know we're having more depression. This is really hard, and that's why it'd be wonderful to have more of you in the room that practice with your clients, but grieving the loss of loved ones, or patients or clients, okay? Grieving the loss of loved ones, because you cannot even go to funerals. You can't be there with them when they're dying, okay? I gave a lecture on Tuesday on grief and COVID. This all kind of comes together. Sometimes it's synchronous in the universe where you're doing these kind of presentations. And this public health nurse, I've never had this happen before, but after the presentation, my email's always at the end of my presentations, and nobody ever emails me, but she did. And she told me that she had been a public health nurse and was one of those, it was a tracer. So if somebody got the illness, she'd try to find out who was around them. And so how did they get that illness? And so it's a big job to be a tracer in public health because you have to kind of track the illness. And she told me that the lecture was so helpful to her because she had so many families that she'd called on the phone or met with because she's trying to trace the origin of the illness, and she's cried with them, and the next time she calls them, she calls them again, and their family member has passed away. And so it was just a profound experience for me to get this email. And then she told me that lecture helped her take control. And she had started to do things for herself, because that was part of what I said in the lecture, things you can do for yourself to make yourself feel better. She was exercising more, eating better, talking about how she's feeling more instead of holding it all in. But this, and I share this example with you because it impacts me. I told her she made my day, because you never know when you give that kind of information to people if it's ever helpful to them. And for her, that one person, I got results from the evaluation. People thought it was a good enough lecture, but she was really profoundly affected by that, and that made me feel good. People are frustrated, cut off by social distancing. I think this is one reason why, there's many reasons why people won't wear masks. There's many reasons why people will still get together, but one of them, I think, is this sense of frustration and anxiety because they cannot connect. That's part of it. Isolation and loneliness only fuels depression. Okay? We are social creatures. We like to get together. I have a dear friend who's extremely introverted, and she told me early on in this 7-month period how much she loved being home. She's not telling me that now. She's not happy that she's still home, but isolation and loneliness fuels that depression. Being cut off from love, support, and close contact of family and friends can really trigger depression or can make existing symptoms worse. Okay? If you're in a troubled relationship in your home, spending months quarantined in a troubled, unhappy, or abusive relationship can be even more damaging to your mood than being alone. And this is something that we've been talking about in my friend group, that we really think that after the pandemic's over and people get the shots, and lots of divorces are going to happen. We think that a lot of people at that point are going to say, I've done it. I'm no longer going to, not like everybody's going to get divorced, but the marriages and the relationships that were not working well is going to contribute, the quarantine is going to contribute to separation. We also think there's going to be a lot more babies after. I don't know why we think that, but maybe people are so excited they're having more sex. I don't know. We know that anxiety can lead to depression and panic and anxiety. I said stress levels up, and to cope, we drink too much, abuse drugs, or overeat junk food in an attempt to self-medicate our mood and deal with stress. So again, these are global losses and communal grief. We all have difficulty with our trust and certainty in the future. Life as we knew it to be before the pandemic, we all kind of grieve that. There's a loss of that, right? We can't go to, I remember in the spring I couldn't go to my son's graduation from college. He had some awards and I wanted to celebrate him. But we couldn't because, that was right in the middle. It was in May. Marriages, right? People can't, even though people are getting married, they're not having the big weddings that they might have planned. So a life as we know it before the pandemic is no longer. Freedom physically and at times psychologically. What I mean by psychologically is we have an inability to fully plan for the future. It's hard for us to see where we're going to be. It's hard for us to know what we're going to do. Especially, I've got a lot of friends whose children graduated from college and they don't have jobs. They can't get jobs. These are kids that would have had a job, and some who were actually let go because once the pandemic hit, they didn't have money in their organization to continue to support them. Routines lost. This is a biggie, biggie. Habit in everyday life is so critically important. We all need our habits and our routines. I don't know about you, but going from an office every day, which I really enjoyed because it gave me that psychological separation from work. I could go to work and come home and have that psychological separation. Now I'm at home all the time. And so my routine was really thrown out the window. And other people's routines have been as well, especially if folks have lost their job. Again, our planning for the future is impaired. We don't know where we're going or our movement in life. This is a huge one for me. Safety in our family and community, state, country, and world. So feeling like we are uncertain about that safety, okay? I also think it's hard because you cannot reassure your children. You can't reassure people that, that they're going to be okay. I'm grateful that my son's 22 and that he has a job and lives separate from me, so he can, I'm grateful that he's a semi-adult, right? A young adult, because I don't feel like I have to protect him like I would if he was an infant or even an adolescent or a school-age child. Obviously, financial means have changed for many people. I talked about the special events and milestones, and we know that the rituals of grief, mourning, and joy have all been altered, okay? I've attended 2 funerals online since I've been in COVID. One was my Aunt Carolyn, who passed away at 88 from congestive heart failure and kidney shutdown, and she was, it wasn't COVID, but it was terrible not to be able to go to her funeral. The other was my great aunt, Mary Fern, who did pass away from 100 years old and passed away from COVID in a nursing home in Texas. So, we've all had these experiences, and we all have not been able to do those rituals of grief, mourning, and joy. One thing I have been doing, and it just hit me yesterday, in my lack of being isolated and not able to be in my community and connect, I've been writing letters. And I was like, oh my gosh, so that's what you're doing to help yourself with that. Writing letters, and it's something, or writing a journal if people want to write journals, or any kind of expression of what you're dealing with, and just to try to reach out to people that I'm not able to see very often. Personal loss and grief, we just said this, drastic. So this is more personally. Globally was before. You can talk to anybody who's going through this, right? And we can all talk about it. Personally, it may be different. I think it's interesting that you guys are coming in here every day about, and I think that's great, because I really think that helps to come in and you got that change. Some people, though, have a drastic change to their schedule. Inability to be comforted when one is ill. So if you or someone you love is ill and you can't get to them because you're isolating or they're isolating, how hard it is to not have that comfort, right? And how hard it is not to be able to give the comfort to somebody who you know is suffering, whether they're severely suffering, as in the hospital, or just suffering. Financial loss, some people have lost their jobs. I'm so grateful I still have a job. I'm still wondering if, I don't know if you know this, but UNM has asked people on South Campus, UNM, not North Campus, that if you work for them and you've been an employee for so many years, you can have voluntary retirement. They're starting to have voluntary, and so you can voluntarily retire. That's an ability for them for UNM to adjust to their financial loss, because they're losing lots of money. People don't talk about it, but it's happening. An ability to be with a loved one when they die. Your social support. Maybe those who you got social support from before are going through a depression because this is hard for them, and they can't help support you, emotionally. Support services, inability to get them. The CARES Act. People have had a hard time, if you're a clinician, people and other just small businesses, people have had a hard time getting the social services they need, applying for them and getting them, right? Employment, ability to fully reassure your children. This is the one that I was really painful. To reassure your children, to feel that you can keep them safe, especially in the unknown, when people do not know what's going on. Cannot connect in person. People may also feel a sense of guilt for grieving over losses that seem less important than the loss of life. So I'm talking about you're sad because your routine is off, but yet your neighbor's husband passed away from COVID. And then you feel like, oh, I feel so guilty for grieving about something, because my routine is off, but she lost her husband, right? So that's another personal loss and grief. So compounding the issues of COVID are that the oldest age are vulnerable. This has been really difficult for people in this country. And because we revere, on the whole, I think we still revere our elders, that 3/4 of all COVID-related deaths are in hospitals. 3/4. And that's not usually where deaths happen. I don't know if you guys know that, but it's not. Usually it's happening at home or in hospice. And people are having bad deaths. We're having physical discomfort, breathing difficulties, psychological distress, unable to follow the preferences of the patients dying. So the patient may want to be at home, but you can't send them home because you're afraid they're going to infect everybody at the house. This is a huge thing. Multiplicity of loss associated with pandemic or disaster. We have so many losses. It's not just one thing. It's many losses, right? Fear and anxiety for self and others. Disruption of cultural norms, rituals, and usual social practices related to death and mourning. I predict that we're going to have some prolonged grief, which is a disorder, prolonged grief disorder reactions, because we've not been able to have those usual practices related to death and mourning. And COVID also affects the ability for an individual to connect with deceased before and after the death, which is so hard. So I am going to give you some ideas about how you might combat that. Change your focus to combat depression, okay? And you can, sometimes I have these kind of things, or if I run across something like this for myself, I actually have it for myself, I like print it out so I can see it. Maintain a routine. I don't care what it is. Whatever that routine is for you. In the summertime, my routine was getting up, going up and downstairs, feeding my cats, and making a good cup of coffee and sitting in the backyard. That's what I did in the morning, every morning. And I made sure I got exercise every day. I walked every day. Eat healthfully. I know I'm a bad snacker. I like to reach for the sugar. That's my favorite thing. Caramels in the fall. It's my favorite thing. Occasionally I'll put an apple with that, which is the healthful part of that. But eat healthfully. Have your snacks be protein, healthy vegetables, water, things like this. Distract yourself. Meditate. I don't know if I have yes, I do have relaxation techniques. Meditate. Distract yourself. I would say start art projects or do some of your hobbies. Find simple sources of joy. My simple source in the morning was knowing that my kitties would be waiting for me to go down the stairs, you know, and with their little paws and wait for me. It was such a joy to them to have me feed them. I mean, they were so cute. And I do it every day. What a miracle that is, right? And just to sit in the backyard and watch the birds and the hummingbirds and just those simple sources of joy. This is huge. Limit your consumption of news, okay? I lived through, I'm from Oklahoma City, and when the bombing happened in 1994, I think, or 95, I can't remember now. When that bombing happened, I watched the news for days. I was so traumatized, I cannot tell you. I knew where they took those patients. They took them to my hospital, the one I worked at in Oklahoma City, St. Anthony's. So the point is that I learned, limit my consumption of news. I'm doing better with this. And anytime certain people are on the news, I just won't watch it because they make my blood pressure go up. Practice mindfulness and relaxation techniques. I would tell you that right now, we have been made to practice mindfulness. I don't know if we're practicing relaxation, but when you get up every day and the same thing's happening to you and you have to get on your computer, you know, all the things you have to do, you have to be in the moment because you don't know what the future is. You absolutely have to be in the moment. Express gratitude. Sometimes people will have a gratitude journal where they will write down 3 things they're grateful for, either every morning or every night. Meet friends in a socially distancing way. We have been doing this, and this is really, really helpful. If I have, we usually have a couple over, we're in the backyard, we're far apart. This helps so much. We laugh so hard. Zoom and Facebook meetings. This is, although I'm sick of Zoom, I'm really tired of it because it's all I do. I do it. I do it with my family in Oklahoma, and I do it with my Uncle Chuck, who's 90. I do it. Share about yourself. Talk about how you're feeling. One of the reasons I share with you in this presentation about my personal experiences is that I'm you. We're one and the same. We all are human beings. And I share about myself to break the taboo of doing that and to also just let you know I'm a human being like yourself. Try to move beyond small talk, right? How are you today? Oh, I'm fine. Try to move beyond small talk. Some people won't do that. I have somebody I know somebody who doesn't like to do that. And I try to honor that. but it's difficult because I know the person is struggling sometimes. Nothing needs to be fixed, okay? You don't need to be fixed. This is natural to feel down. This is natural to have, unless you're getting severely depressed or suicidal, and then you definitely need, or having functional problems, then you definitely need to seek help. Try to get, sleep is such a good, I don't know if you guys have ever had trouble with your computer and you reboot it and, oh my God, it works again, right? We are like computers. If we can get ourselves a good sleep, we can feel 100% better the next day. Personally, when I do an assessment on anybody, if I don't talk about sleep and their hygiene, and what I mean by that is what do they do before bed? Do they drink anything with caffeine in it? Do they watch, I don't know if you guys have, there's a show called The Last Kingdom on TV right now, and it's about fighting and swords and blood and stuff. Don't watch that before bed because that'll really keep you up. But I talk to people about what they're doing so we can get them to have a good night's sleep. And just reminders for yourself to keep you on track. Reminders, stickies. I have things up in my office that are just quotes that make me think good. Like, what would you do today if you knew you could succeed? You know, or I don't know. I love quotes because it helps condense these ideas for me. This pandemic could be an opportunity to improve mental health services. This was written by Moreno, Wykes, Galdersi, Nortendoff, Crossley et al. The interconnectedness of the world made society vulnerable to this infection, COVID, but it also provides an infrastructure to address previous systems' failings by disseminating good practices that can result in a sustained, efficient, and equitable delivery of mental health care delivery. Do not despair. Do not despair. We must hold our leaders' feet to the fire about this. We must have a better healthcare system. We must have a better mental health care system. We cannot let this fail. And people are writing about it. People are talking about it. This is a beautiful little video that I wanted to play for you, but we can't get it to work today. But you can find this for yourself. This is on, you go to YouTube, you put down Michelle Obama, First Lady. You could put podcast, or you could put depression in that search, and this will come up. It's about a 3-minute video. But what I loved about it, what I loved about it is you may or may not know that she started a podcast I believe in July or early August, and it's sponsored by Spotify. It came on Spotify, but it's probably on Apple and some other places too. But this podcast is charming. If anybody has ever listened to her or read her book, Becoming, which is a beautiful book, easy to read. And I like Audible books. I heard it on Audible, and she's narrating it. But in this, this is a clip from CBS Morning News with Gail, can't think of her last name. I love Gail King. Anyway, they were talking about the fact, and they played the small portion of the podcast that she talked about a low-grade depression she's been going through. What a hero she is, and what a spectacular role model for us. Because she talked about how hard it's been. I've been dealing with something, she said, some kind of low-grade depression in the mornings. I get up and I just feel so sad about the state of our nation, and it's COVID, and it's how mean people are to each other. And it's an absolutely beautiful expression of her own struggles. And so, and the reason it's important to me is that we all need to, again, know that somebody as wonderful and as outgoing and as optimistic as our former First Lady can actually have depression. So it's okay if others of us have it as well. I certainly have had depression in my lifetime. That's probably what got me to do the work I do today. But I really admire her. So I really encourage you to go on and see it. It'll be a treat for you. And I encourage you to listen to the podcast. I was listening to it on the way here this morning. I had it up, I guess, yesterday, and I plugged my phone in, and there it went. And they were talking about, she was meeting with Conan O'Brien. They're talking about marriage. Oh my gosh. Well, I'm married, so that was helpful to me. It was because I always get something I can reflect upon in my own life, and it was lovely. So I really encourage you guys to go ahead and look at that. So we have till 10:30? 10:45? Okay. Would it be a good time for people to take a break and be back in 10 minutes? What? 15? Okay. Well, we're going to really go fast through the other ones. That sounds good.